So why is chronic subdural hematoma important? So I think, firstly, they're very common. Probably it's the most common emergency operation that we do in the UK, and I think this also applies to other Western countries. And I think, you know, there is now some good evidence that the number of chronic subdural hematoma operations is going to keep increasing in the next few years. We have an aging population, and also many people are now using blood thinning medications. So I think we'll be seeing more and more of these cases. It mainly affects the elderly, and as we know, the elderly also have other comorbidities, other medical conditions. So again, this is a very frail population, and often operating on those patients can be challenging. You know, they can also develop other postoperative complications and issues that can affect outcome. As I said, the incidence of chronic subdural is expected to rise. And despite the big number of patients, we have very few prospective studies. So if somebody takes a look online, you will see that many of the studies that have been published, they're actually retrospective. And as a result of this, we have many unanswered questions. And I think, firstly, to try and set the scene, I will try and answer with a very vivid example why research is important. I think many of you are familiar with this paper that was published back in 2009 in The Lancet. So this was a randomized controlled trial that was conducted in Cambridge. I wasn't in Cambridge at that point, so I wasn't involved in the study. But you can see that almost 270 patients were randomized in the study to receive a subdural drain or no subdural drain after bare home drainage. And as you can see here, in this study, the recurrence rate was 9% in those who had a drain versus 24% in those that did not have a drain. So a significant reduction in the risk of recurrence with the use of a drain. You can see the p-value there. And also you can see that at 6 months, it seemed that there was an association with lower mortality for patients who had a drain versus no drain. And also a trend in terms of the modifier ranking and better outcomes in patients who had a drain. And again, it has to be said that, you know, people say, oh, you know, were you not using subdural drains before? And the answer is that before this randomized trial in the UK, very few surgeons were using a subdural drain. I don't know what the situation was in Turkey, for example, but I do know, and we have actually the evidence from a survey that we have conducted, that less than 25% of the surgeons were using a subdural drain. And then this is a nice paper that was published in the ACTA a few years back. And basically it shows that high quality studies like this randomized trial in the Lancet can change clinical practice. So these authors from King's College Hospital in London, they also found that the use of drains increased from 17% to 35% after the trial was published. And then once they presented the trial results in 2015, the use of drains went up to 75%. And you can see that, you know, clearly just publishing the results isn't enough. We need to be actively disseminating these results. We need to be discussing all of these important studies in our journal clubs. And, you know, certainly webinars like the webinar that I'm presenting today, I'm hoping that they will be helping in that direction. So coming back to the main theme, which is what kind of questions are still pending in the field of chronic subdural. So this is a paper that we published a few years ago. And I think that we have unanswered questions in terms of the methodology of research, in terms of the surgical technique, in terms of adjuvant pharmacological therapies, and also in terms of the postoperative care. And I will try and cover briefly each one of these points. So in terms of trial methodology, we have been trying to develop a core outcome set. This is really an agreed set of outcomes that should be measured and reported as a minimum. So this is not to say that we should only be measuring these outcomes that are included in the core outcome set, but this is just the minimum standard. And this would apply to all clinical trials or other high quality studies in specific areas. you may have seen the terminology used in the USA, which is common data elements. It's a similar concept. The core outcome sets, what they can do is they can increase the consistency across studies. This means that then there is more potential for a study to contribute to systematic reviews. I'm sure that many of you who may have tried to do a systematic review, they will have found problems simply because different studies measure different things at different time points and different definitions. And then also studies which use the core outcome set, they'll be much more likely to measure the right outcomes. And you can see that this is a paper that we published, and this was a systematic review trying to find out what exactly was being measured and presented in the chronic subdural hematoma field. And we categorize the outcomes in these domains. So mortality is commonly reported. So you can see 64% of the studies that we included. Complications, almost half of the studies. Recurrence in 95% of the studies, so almost all of them. Functional outcome, which is actually what matters to the patients, in only 40% of the studies, and then radiological outcome, again, about 40%. And you can look at recurrence as an example of heterogeneity. So in the 96 studies that we included, you can see that 20% of those, they had no definition of recurrence. So people just said that we looked at recurrence, but we couldn't actually work out what recurrence means. In some studies, recurrence was defined as reoperation only. In other studies, as radiological recurrence. In other studies, radiological recurrence requiring reoperation. So you can get an idea about the fact that there doesn't seem to be any consistency in how we use the term recurrence. So we have now published a protocol of this code CSDH project, which is currently led by two dear colleagues of mine. Dana Hall is a PhD student in the Netherlands, and Ellie Edelman is a clinical lecturer in neurosurgical registrar in Plymouth. And we have already completed the systematic review phase of the study, and we have now completed the first Delphi round. So we're about to do a second Delphi round, and then we'll have a consensus conference to come up with a core outcome set. So, you know, what are the outcomes that we should be measuring? So moving on to the surgical technique side of things. And this was a study that I'm very proud of. This was a prospective observational study that we conducted in the UK. This was a study that we rolled out in 2013. So at that point, I was still a resident. And you can see that we developed the British Neurosurgical Trainee Research Collaborative. So this was a network of trainees coming together from several UK neurosurgical units and basically try and collect data at the same time on patients with chronic subdural hematoma. So we had a protocol that we published, and then you can see the recruitment. So we actually collect data on 1,200 patients. So I think actually that this is the biggest prospective observation study in the field. You can see that we collected data from 26 out of the 32 adult neurosurgical units in the UK and Ireland. And this was a paper that we published in the JNS in 2016. We had quite a few co-authors in the byline, but also lots of collaborators that were all cited on PubMed. And actually, if you look them up on PubMed, this paper is coming up if you search, for example, the name of Ashari. So I said this was a prospective observational multi-center study. Of those 1,200 patients, 823 were transferred and managed in a neurosurgical unit. The median age of those patients was 77, as you would expect. 68% were male, and about 2/3 had a documented history of head injury in the preceding 3 months. And almost half of them were on a blood thinning medication at the time of referral. And you can see that, as I said, those patients have a lot of comorbid conditions, and many of them are frail, so ischemic heart disease, arrhythmias, diabetes, and cerebrovascular disease. So in terms of the management, and this was just really describing the management, so the study didn't have any influence on the management. We're just collecting data and describing the management. So the use of steroids was not very popular in the UK. Only 3% had a course of dexamethasone. But as I said, about half of the patients were on an anticoagulant or antiplatelet medication. And of those taking aspirin, 30% had a transfusion of platelets preoperatively. This was usually in the context of not being able to wait for 5 to 10 days for the aspirin effect to wear off. Surgical treatment, and in the UK, for historic reasons, we tend to operate on these patients under general anesthesia, but I think that there is clearly a role for local anesthetic techniques. And again, historically, most of these cases we have been using a burr hole craniostomy. So this is typically 2 burr holes under a general anesthetic. But you can see that also about 10% of the patients had a craniotomy, and this can be either a small craniotomy or even a slightly larger craniotomy, but not a trauma craniotomy, for example. And you can see that the recurrence rate in this study was 9%. So in fact, really low, as low as in the drain arm of the Lancet paper that I showed you before. And when we looked at the factors which influence the risk of recurrence within 60 days, you can see that patients with a lower GCS score had a higher risk of recurrence. That's a p-value. This is a multivariate analysis. Interestingly, the use of blood thinning medications was not associated with the risk of recurrence. Probably this is because we are very good at reversing those agents, either with platelets or vitamin K or Beriplex. And then we also found that the use of a drain was associated with a lower risk of recurrence. Okay. When you looked at the functional outcome, and I appreciate that this was only the modifier ranking score at discharge, so we didn't look at the long-term functional outcome, and we defined poor outcome as an MRS of 4 to 6 at discharge. So these were patients who were dependent, an MRS of 4, 5, patients who were really dependent, unable to mobilize at all, and 6, obviously, patients who were dead. And you can see that 22% of those of the patients had a poor outcome at discharge. And you can see the shift from the poorer, so with the dark column is the preoperative, the light gray is the postoperative, and you can see how we have a shift towards a better end of the outcome spectrum postoperatively. Oh, sorry. Yeah, sorry for this interruption. When we looked at the multivariate analysis and the functional outcome at discharge, interestingly, what we found was that the use of more than 1 burr holes was, so basically 2 burr holes, was associated with a better outcome. The use of bed rest postoperatively was associated with worse outcome. You know, that's something that is important to bear in mind, because I know that people are still using postoperative bed rest for these patients. So actually we found, opposite to what you would expect, that bed rest postoperatively is associated with a worse outcome. And then we also found that the use of drain is associated with a better outcome. We also did some other secondary analyses, and this was a paper that we published in Neurosurgery. So we want to simply look at the position of the subdural drain, and we found that with the frontal, using the frontal burr hole to insert the subdural drain, the risk of recurrence was 6.7%, whereas using the parietal burr hole to insert the drain, the risk of recurrence was 8.8%. So just slightly higher, but not statistically significant difference there. I mean, my personal practice is that I'm always inserting I'm always using 2 burr holes if I'm using a general anesthetic technique. and then I'm inserting the subdural drain through the frontal bear hole, aiming anteriorly. Now, we also looked at the use of subgaleal drains, and subgaleal drains haven't been very popular in the UK. I think that's because of the Centaurus trial. And again, you can see that with a subdural drain, the risk of recurrence was 7.7%, with a subgaleal 9.1, so just slightly higher, but again, not statistically significant. Again, I mean, my personal practice is I would only use a subgaleal drain if the brain had expanded to the extent that it was unsafe to insert a subdural drain. And you know, in my practice so far, actually, I think I've only come across this once in somebody who was quite young. So it's not something that happens frequently, especially if you use the frontal bear hole to insert the drain. In terms of the recurrence rates, when we looked at postoperative drains for 1 versus 2 days, again, you can see 6.4% with 1 day of drainage versus 8.4% with 2 days of drainage. Again, just slightly lower with 1 day, which doesn't quite make sense, but statistically not significant. And I think that's one of the problems with observational studies, that because, you know, they're not randomized, even though you have a controlled group, it's often not possible to adjust for all known and unknown covariates, and that's one of the issues with non-randomized studies. We also looked at some other secondary questions. So one question was about operating on patients who are in coma. And as you know, many of these patients actually, when they present to us, the vast majority are not in coma. They have a GCS between 13 to 15. The vast majority are in coma. And in fact, that was in keeping with our study. So only 31 patients were in coma when they present to us. The risk of recurrence was slightly higher, so 20%. And but you can see that a poor outcome at discharge was 39% in those comatose patients. So that means that about 60% actually, they did have a very good recovery. And then the risk of death was 6.3% versus 1.9% in patients who were not in coma. So, you know, I think the message from this is that even though somebody might be in coma with a chronic subdural, the prognosis isn't necessarily as bad in let's say, what it might have been in patients with an acute subdural. It is slightly different, I think. It's a different pathology. Of course, I have to be honest and acknowledge the selection bias, because this was an observation study. Again, we don't know if the surgeons have already pre-excluded patients and they've decided not to operate on. And then we also want to look at patients who are in their 90s, and we had 68 of those patients. You can see that the risk of recurrence was about 12%. A poor MRS at discharge was observed in 40% of those, so double what was observed in patients below the age of 90. And also you can see that half of those did not have any improvement when you compare admission to discharge MRS, compared to about a third in those who were below the age of 90. And 9% of those died compared to 1% in patients below the age of 90. So again, you know, clearly patients who are in their 90s, they don't do as well as younger patients. But again, I wouldn't look at this data and say that there is no point in operating on somebody who's over the age of 90. I think, you know, we need to have the discussion with the next of kin, with the family and the patient if they're in a position to decide for themselves. But, you know, I wouldn't looking at this data, I wouldn't say that operating on somebody who's in their 90s with a chronic subdural is completely out of the question. One of the other analyses that we did was to look at the patients who had a post-op scan. And again, in the UK, we don't always get a post-op scan, and we only get a post-op scan if clinically indicated. And we had 319 patients who had a post-op scan. You can see that 85% of those had a drain versus 14% who did not have a drain. And again, you can see that the recurrence risk was 10% in those with a drain, 20% in those without a drain. But then what was interesting was that the overall change in the median subdural width was much greater in patients with a drain. So we had a reduction in the width of the subdural of 11 millimeters with a drain versus 6 millimeters without a drain. And also the reduction in the midline safety was also greater in the drain group, so 4 millimeters versus 3 millimeters. And then we also, when we did a multivariate analysis, we saw that the reduction in the width of the subdural and the midline shift were significant predictors of recurrence. So I think that is a nice way of demonstrating how subdural drains work. And, you know, I say that's just something interesting that we saw when we analyzed the data. So moving on to the pharmacological therapies. And I'm going to talk really only about the steroids in chronic subdural hematoma. So this was a randomized study that we published late last year. And this was funded by the NIHR. So this is the equivalent of the NIH in the US. It's called National Institute for Health Research. So there was a commission call that they advertised in 2013, and then we applied with the National Society and also with the trainee group that I mentioned before. We were lucky to get a grant for £1.35 million, you know, quite expensive, but not as expensive as some of the pharma trials, which can be in the region of, you know, 40, 50, 100 million pounds or dollars. And why did we want to do this trial? As said to you, CSDH is common instances writing, and there was some non-randomized evidence that steroids may be able to reduce the risk of recurrence and prevent the need for surgery in patients with mild symptoms. Interestingly, when you look at the systematic reviews, which is what you do when you have this kind of questions, so this was a review published in the Annals of Surgery, so a very good surgical journal with high impact factor. And you can see that they concluded that higher morbidity was associated with the adjuvant use of steroids. So adjuvant meaning that they were given in addition to surgery with no significant improvement in recurrence or cure rates. And then another systematic review published in the European Journal of Neurology, again, a very good neurological journal. And the conclusion was that 5 observational studies suggest that steroids might be beneficial in the treatment of chronic subdural. However, there is a lack of well-designed trials. And therefore, the authors encourage the conduct of randomized trials. So in terms of the study design, the hypothesis that we have was that dexamethasone, as compared with matching placebo, improves the 6-month functional outcome in patients with symptomatic chronic subdural by reducing the need for surgical interventions and postoperative recurrence. And this was a randomized placebo-controlled trial of a 2-week course dexamethasone, and we used a tapering course. So as you can see, 8 milligrams BD for the first 3 days, going down to 6 milligrams BD for the next 3 days, 4 milligrams BD for the following 3 days, and then coming down to 2 milligrams BD for days 10, 11, 12, 2 milligrams once a day for days 13 and 14, and then stop. And as I said, patients who were on the placebo arm, they received exactly the same capsule. So there was no way of knowing what the patient was having. So patients were excluded if they had conditions for which glucocorticoids were contraindicated, so infections, GI bleed, peptic ulcers. And as I said, the patients, the clinicians, and the researchers were all blinded. And the medication was started within 72 hours of admission to the neurosurgical unit. The reason we had said 72 hours is simply to try and accommodate all the processes to get somebody into the randomized trial. But the aim was to try and enroll patients and start the medication as soon as possible after admission. And because this was a pragmatic study, what we had said is that the decision to evacuate the chronic subdural and also the timing of this operation was completely at the discretion of the treating clinical team. And because I said this was a blinded, we were hoping that really which arm the patient would end up into, so steroids or placebo, wouldn't really affect the decision to evacuate the subdural. The primary outcome was the modified Rankin scale at 6 months. And as I said, it was important in our view to have a functional outcome scale, not just the recurrence. And just to remind everyone, the modified Rankin scale ranges from 0, which is patients with no symptoms, 1 is no significant disability, 2 is slight disability, somebody who can look after their own affairs without assistance, but unable to do exactly what they were doing before. 3 is moderate disability, so somebody who needs some help but able to walk unassisted. And traditionally in chronic subdural hematoma trials, we take 0 to 3 as a good outcome. And then 4 is moderately severe, so somebody who's unable to attend to own bodily needs without assistance, unable to walk unassisted. 5 is somebody who is bedridden, so spending the whole day on a bed, incontinent. 6 is somebody who's dead. And the modified Rankin scale at 6 months was the primary outcome. Secondary outcomes, we had MRS at discharge at 3 months, then the number of operations, then the GCS, Bartel, and quality of life, mortality at 30 days, length of stay, and also adverse events and health economic analysis. So the aim was to randomize 750 patients in order to see a difference in terms of the favorable outcome coming from about 80% to 88 or 85 to 93%. So an 8% absolute improvement in the proportion of patients who have a good outcome at 6 months. And as this was a randomized trial, we had an intention to treat analysis, which means that all patients were randomized according to the arm they were allocated into. And then we also had some secondary analysis, and one of them was a per protocol, which excluded patients who had less than 80% of the medication or who were given more than 8 milligrams of dexamethasone if they were in the placebo group. And then we also had some exploratory subgroup analysis, looking at the patient's age, time of head trauma, use of blood thinning medications, admission GCS, and bilateral chronic subdural. So this was a study that actually randomized 750 patients relatively quickly, so just over 3 years. And you can see that many of those patients were randomized in Cambridge. This is not surprising, we were the coordinating site. But you can see that several sites in the UK recruited lots of patients. Certainly more than 10 sites recruited more than 10 patients. And you can see that we randomized 750 patients. 2 were immediately excluded, as were ineligible, so we come down 748. And of those, 375 were assigned to dexamethasone. 363 actually received dexamethasone. On the other side of the placebo arm, 373 were assigned to placebo, and 361 actually received the placebo. So the main reason for patients not receiving dexamethasone or placebo was the size. Believe it or not, it was the size of the capsule. So many patients just could not swallow the capsule because of its size. And then you can see that at 3 months, 9 patients had been lost to follow-up, and 20 had withdrawn consent. 1 lost follow-up in the placebo arm, 22 withdrawn consent. But then at 6 months, we had been able to locate some of those that had been lost at the 3-month point. So we end up anyway with 341 patients with data at 6 months in the dexamethasone and 339 with data at 6 months in the placebo arm. So looking at the results, the baseline characteristics were balanced between the 2 arms, and this is one of the nice things with a randomized study. You don't, especially if it is big enough, you don't really have to worry about any imbalance between the arms of the study. So you can see that the age was about 75 in both arms. About 70% were male. in terms of the presenting symptoms, again, what you normally expect, so headache, mobility problems, cognitive impairment, hyparesis in about 30%, speech problems like dysphagia, aphasia in 20%. And then also when we looked at the modifier ranking scale score at admission, you can see that 40% had an MRS of 4 to 5, so we're significantly affected by this. But as I said to you, the vast majority had a good GCS of 13 to 15. Some more baseline data. So more than 2/3 had head trauma reported in the preceding months. Almost half of them were on the blood thinning tablet. 22% had a bilateral chronic subdural, but the imaging data were comparable between the two arms. And in summary, 40% had midline safety of more than 10 millimeters. About 40% had 5 to 10, and about 20% had less than 5 millimeters. 94% of the patients had primary surgical evacuation, which was done either at the index admission or a subsequent admission. But this means that 6% of the patients were managed without an operation primarily. And again, as I mentioned to you, in the UK, we tend to use burr holes. 90%, almost 90% had a burr hole. Again, almost 9% has had a subdural drain inserted. These are the results of the MRS at 6 months. So just briefly to orientate you. So we have always the dexamethasone on the left, and we have the placebo on the right. And this is here the discharge MRS. Here we have the MRS at 3 months, and then the MRS at 6 months. And we have color-coded the MRS. So the poor MRS is color-coded as red, amber, and yellow. So this is 6, 5, and 4. And you can see immediately that at discharge, patients in the dexamethasone arm had poorer outcomes. This is even more pronounced at 3 months, and at 6 months seems fairly stable. So when we look at the patients, proportion of patients with a favorable, so a good MRS at 6 months, that's a primary analysis. 84% of patients in the dexamethasone group had a good MRS versus 90% in the placebo group. So actually opposite what we hypothesized when we started the study, patients in the dexamethasone group had a worse outcome. And say this was surprising for us. In fact, so much that we had to ask the statistician to double check that the analysis had been done correctly. But they confirmed to us that it had been done correctly. They had double and triple checked everything. And the p-value was significant there, as you can see. Also, if you look at the ordinal outcomes, again, and you look at the patients who died, so there was a trend towards a higher mortality with dexamethasone compared to placebo. When we adjusted for age and GCS at admission, again, the odds ratio is 0.55. And again, you can see that the p-value is significant. And when we did the per protocol analysis, as I say, to exclude those patients who had less than 8% of dexamethasone or 2 months dexamethasone in the placebo arm, again, you can see that the result is pretty much the same. And at the 3 months, the difference was even greater, so 8.2%. Now, looking at the secondary outcomes, and I think this is where it gets really, really interesting. If you look at the highlighted, which is the repeat surgery for recurrence, with dexamethasone, actually, we managed to get the risk of recurrence down to 1.7%. And I think this is probably one of the lowest recurrence risks ever recorded. With the placebo, it was 7%, so it was actually lower compared to the Lancet paper, and lower even compared to the JNS papers. It's also very, very low, but there is no doubt with the use of dexamethasone, the risk of recurrence was lower. But when you look now at the adverse events, the serious adverse events, There were significantly more of those in the dexamethasone arm. 16% of the patients had one compared to placebo 6.4%. And also the adverse events of special interest. So these were any dexamethasone-related adverse events like hyperglycemia, diabetes of new onset, psychosis, etc. Again, 11% versus 3%. So there was no doubt that the use of dexamethasone was associated with more adverse events. I think this possibly something that we had underestimated when we started the study. But being honest with you, when we had looked at other published papers, many other papers were reporting the use of steroids for a much longer duration. So the 14 days is one of the lowest if you look at all published papers. And I say this is just about the adverse events of special interest that I mentioned. Again, with infections, 6.4% risk of infection with dexamethasone, 1.1% with placebo. This is not just the surgical site infections, it's all infections. When we looked at the patients who did not have an operation, and as said, we have 38 patients in the whole study. Interestingly, 82%, we found a very similar result as in the overall study. So 82% in the 82% of patients in the dexamethasone group of those who had a conservative management had a good outcome at 6 months versus all of those in the placebo group. So again, a result which was similar as the overall study. So in terms of conclusion of the study, what we thought is a prudent conclusion is that among adults with symptomatic chronic subdural, most of whom had surgery to remove their hematomas, treatment with dexamethasone resulted in fewer favorable outcomes and more adverse events than placebo at 6 months, but fewer repeat operations were performed in the dexamethasone group. And this was a conclusion from the New England Journal of Medicine paper. And as I say, the editors had a lot of influence on the exact phrasing of this conclusion. But I think it is a fair description of the findings. In terms of the implications of this study in clinical practice, I think we have very clear evidence for the first time that patients treated with dexamethasone did worse than the placebo patients. The majority of patients in the study had surgery. So it's very clear that dexamethasone should not be used as an adjunct to surgery. We had a few patients who were managed conservatively, only 6%. So I think we are less confident in saying that dexamethasone should not be used as standalone therapy. Having said that, there was a study, I don't know how many of you may have seen this, but there was a randomized study that was being conducted in the Netherlands in 3 sites. It was called the DEXA study, and they actually presented their results recently at the EANS meeting, the recent EANS meeting. And again, they found very similar outcomes to our study. And I say this was a study where they compared dexamethasone to surgical treatment, and the study had to stop early because patients in the dexamethasone arm were doing much, much worse compared to the surgical patients. So based on these results, we recommend that the use of dexamethasone for chronic subdural should be avoided unless it is happening as part of a research study. I think it's also important to say that we have established that surgery for chronic subdural has a very good safety profile with, excuse me, with 90% of patients in the control group having a good outcome at 6 months and almost 2/3 going back to their usual activities. The recurrence rate is getting lower, so the 7% of the control group is one of the lowest ever reported in a multi-center study. So on this basis, we think that we should be focusing on the role of rehabilitation, trying to involve geriatricians, and also the role of minimally invasive techniques like bedside tissue craniostomy, middle meningeal artery, and also the role of performing surgery under local anesthetic. The study, as I said, would not have been feasible without the funding from the NIHR. but also particularly to thank the patients and their families for taking part in the study. Importantly, all the collaborating clinicians and the research staff, but also the members of the trial steering committee and the data monitoring and ethics committee. If you visit nejm.org, you'll be able to see our paper online. So coming now on to the final part of my presentation, and I think really it's just one more thing to mention. This was a study that was also published in the New England Journal of Medicine. So this was a randomized study that did a very simple, they had a very simple question. So they randomized patients with a chronic subdural hematoma within 48 hours after surgery to either a combined CT and clinical follow-up or clinical follow-up only with scans performed only if there was a clinical reason, so neurological deterioration basically. And what they found interestingly was that the number of patients who survived without severe disability, so again, MRS, a good MRS of 0 to 3, was 89% in the CT arm and 93% in the no CT arm. So, again, I think, that's a beautiful study. It just shows that actually performing a CT scan routinely is probably not necessary in these patients. So they can be followed up clinically. And this obviously has health economic implications as well, especially in healthcare systems where patients often have to pay for these scans. So to conclude, I think we have covered a lot of things. We have discussed about trial methodology and how we can improve the methodology of research studies in chronic subdural. We have discussed about surgical technique and the evidence from recent studies. We have discussed about the use of steroids, the evidence from randomized studies, and the fact that, in my view, we should be avoiding the use of steroids in patients with chronic subdural. And we have also briefly discussed about perioperative care. I think in terms of the future, I think we should be working together a lot more, and there is clearly a potential for prospective multinational, multi-center observation studies. If I may advertise a book that we have recently published with Steve Hannibal. So this was a Springer book looking at traumatic brain injury. If you have a QR code generator on your QR code app on your phone, you should be able to go directly onto that Springer page. I have to say that I'm not benefiting at all from anybody who buys this book, because that's the agreements that Springer make nowadays. But I say I think that it is a genuinely good book. And finally, just to thank my colleagues in Cambridge, but also outside Cambridge. If anybody uses Twitter, I am on Twitter. That's my Twitter account and my email address. And I think that's pretty much everything. Sorry if it's taken a little while.
Thank you very much for the excellent presentation. There are some questions and thanks. Before the start discussion part, I would like to ask you a question about twist drill craniostomy or twist drill craniostomy with hollow scripts.
Yeah.
How often do you use it in your clinical practice?
Yeah, so I'll be honest with you. So you may have seen the paper that I published some years ago. It was a systematic review. But, despite that, we haven't been able to get on and use it. So I'm not really using the hollow screws at all. We want to initiate a study, but it just didn't happen so far. But I have now renewed enthusiasm, actually, because we have some issues with COVID in terms of reduced access to operating rooms, etc. All of those things have been affected. So I have now renewed enthusiasm to pursue minimally invasive techniques and try and perform as many of these cases under a local anesthetic. So yes, I'll let you know maybe in a few years' time if you invite me again.
Thank you. Another question. What is your surgical approach in recurrent chronic subdural hematose cases? Evacuation from previous burr hole or new knee craniotomy or large craniotomy?
Yeah, so that's a good question, and it is something that thankfully we don't face very frequently. I showed you the recurrence rate, but it can be difficult. So the answer is that at the primary recurrence, I would look at the CT scan, see what the CT scan looks like. If there is lots of hyperdense components or lots of membranes, then I would be thinking about a mini craniotomy. But if it all looks like homogeneous, with no significant hyperdense components, then I would just simply open again the burr holes and just leave it draining again. I think if we are then talking about a second recurrence, so effectively a third operation, I would be a bit more inclined perhaps to convert to a mini craniotomy or a medium craniotomy, if you like, or something like that. But say again, thankfully this doesn't happen very often. But again, if you have multiple recurrences, then you might need to think about options like a subdural peritoneal conduit, that can be used, or potentially, some off-license use of tranexamic acid, for a few doses. Potentially, I have used that as well. And if we have multiple recurrences, this is one indication where I will be thinking about middle meningeal artery embolization. It's not something that we use in the UK. In the UK, the NHS is a public healthcare system. So, there are a lot of pressures, and, at the moment, I don't think that we have enough interventional neuroradiologists to perform stroke thrombectomies and embolectomies, let alone performing middle meningeal artery embolizations. That's the truthful answer. But also my personal view is that surgery is very, very safe. It has a very good safety profile. The risk of recurrence, if done properly, is really low. We have shown in the multi-center studies 7%. That's really, really low. So I would only personally consider MMA embolization in multiple recurrences.
Thank you for answers. I want to go on. Dr. Tahsin Atmaca from our clinic, he is a resident, say that, do you recommend anticonvulsant therapy in patients with chronic subdural hematoma who do not present with seizures? Do you apply routine antiepileptic treatment in your clinic? Murat Bey, can you?
Yeah, great, thank you. I've done it. Again, a good question. So no, actually, so we don't use prophylactic antiepileptics. We would use antiepileptics if somebody presents with seizures or if somebody develops seizures post-op. Again, thankfully, this doesn't happen very often. But I think, this is a frail population with comorbidities. They often have cognitive issues pre-existing or because of chronic subdural. I mean, we shouldn't discount the cognitive side effects of antiepileptics. I know that people nowadays say, oh, Keppra, Keppra is such a great, I don't know if you use Keppra a lot in Turkey, but, nowadays people say, oh, Keppra is such a great drug, doesn't have side effects. But I think nowadays there are lots of publications in head injury patients which show the cognitive side effects of Keppra. So I think we shouldn't underestimate those side effects. So the answer is that we don't actually use prophylactic antiepileptics in chronic subdural hematoma patients.
Thank you. Another questions from Nurullah Kösmene. He is a resident in our clinic. Firstly, say that thank you, sir. It was great presentation. What are your recommendations to prevent postoperative tension pneumocephalus? Does placing a drain prevent tension pneumocephalus?
Yeah, a good question. So the way we perform these operations is that we use a double burr hole technique. I would only use a single burr hole if I'm doing this under a local anesthetic, for obvious reasons, just to get on and do it quickly. But because we do most of this under general, we do 2 burr holes, and we place one sort of just above the superior and temporal line, and one further back of the parietal region, and then we always insert the drain through the frontal burr hole, aiming anteriorly. And I know that some people, they try to insert the drain all the way from the parietal burr hole to get to the frontal pole. I think, this just carries an unnecessary risk, because when the brain then expands and you have to pull this all out, you can very easily lacerate the, the cortical surface, end up with an acute subdural. And these things are reported. There was a randomized trial that looked at subgaleal and subdural drains published in Neurosurgery. It was conducted actually in Switzerland. I think the lead author was Yehuda Soleiman. And you may have seen that they had a 15% misplacement rate with subdural drains, which is way off what our experience is. And they were using this technique that I described. So, try to put the drain all the way from the back to the front. And I think, that's the reason. So in our practice, we always insert the drain through the frontal burr hole, aiming anteriorly, and we close the skin in the parietal burr hole, and then close the galea, close the skin. And then as we're about to tie the final knot, we are filling up the subdural space through the drain with saline. So, this is just simply to fill up the space, and this is how we can minimize the pneumocephalus postoperatively. And, if you're happy about the position of the drain, or the tip of the drain, that, it's not in drain or anything like that. And I say, I never insert a huge length of the drain. Normally I insert no more than this in the subdural space. So, I fill it up. I fill up the subdural space through the drain with saline, and then you can nicely see, because you haven't fully closed the skin, you can nicely see the air bubbles coming out. And then once you see a jet of saline coming out with no air bubbles, this means that your subdural space is pretty much full of fluid. It's just a very simple method. And then this is when you stop and you tie the knot and you close the skin, and that's it. And then, this isn't going to be under pressure, because you have now left a drain in. And, this drain will be draining freely. So all of this fluid is going to gradually come out. You see it coming out straight away. With every pulsation of the brain, you see it coming out. And then I say we keep it for a couple of days, and we take it out, and that's it. And we don't do a scan unless there is a specific reason, unless there is specific concern. I don't know if that answered the question.
And second question.
Good. Go on. Go on.
And his second question about subdural membranes. Does the presence of subdural membranes change the surgical technique? Have you ever done a craniotomy to exercise to the subdural membrane? Thank you.
Thank you. Again, it's a good question. So I think we have to try and distinguish the membranes. So you have those membranes which are in the subdural space, and you also have those membranes which we call visceral membranes, which are really and properly adherent onto the brain surface. And you can see that they give to the brain this kind of yellowish tints, and there's clearly a membrane, but you can see the vessels of the brain surface underneath. So those membranes which are adherent on the brain surface, we just never touch. I've never done so, and nobody, in my unit has done so. So, it's it's very historical that we never touch. And actually, because you can see the vessels of the cortical surface underneath, by definition, there isn't any collection there underneath. On the other hand, the membranes which are in the subdural space, what I always try and do is I try and, just through the burr holes, normally, those burr holes are 14 millimeters. So if you really coagulate back the dural leaflets, you have enough space to easily get, a suction device in a suction cannula, and also, a sharp hook or a blunt hook or something, a micro instrument, and just gently tease them apart, open the So I always try and open those subdural membranes which are in the subdural space. And then you often see that there is more fluid coming out. And if there is another one underneath, I will also open that one. And I think all it takes is just open a little bit of that membrane then, and you can do that under direct vision with the scissors. You make an opening big enough, and then you've washed out all of the subdural fluid. And I think in my practice, I've seen that this is more than enough. So in terms of membranectomy, no, I've never done that. And, at least looking at the practice in my unit and also that of my colleagues in the same unit, it's not something we do. It's not something we consider essential.
Thank you, sir, for answers. Dr. Mehmet Seçer from Turkey, Alanya Education and Research Hospital. He has two questions. Firstly, say that, do you have experience with the effects of atorvastatin on chronic subdural hematoma?
Again, thank you. Good question. I didn't mention it because, obviously, spend quite a bit of time. So no, so I don't have any direct experience of that, but there have been studies published mainly from China, and a Chinese group published a good multi-center phase 2 study in JAMA neurology a few years ago, and they saw good outcomes with atorvastatin, but again, they didn't look at functional outcomes. So they didn't look at how patients are at 6 months, and I think that is important. And if I may briefly digress from what we're discussing, I'll tell you why this is important. Imagine this dexamethasone randomized trial that we published in the NEJM. If we hadn't collected the modifier ranking scale at 6 months, and we had only collected the recurrence data, now everybody would be using dexamethasone to reduce the risk of recurrence from 7% to 1% or whatever it was. But actually, we would be harming patients because it was very clear in the study at 3 months and 6 months that patients who had dexamethasone actually were worse. And I think that's why we should be doing our best to collect outcomes which are relevant to patients. So how are the patients at 3 months, 6 months, whatever? So we shouldn't be using just data on recurrence or data which are only important to us as surgeons. I mean, don't get me wrong, recurrence is very important, but I would argue that it's much more important how the patients are. So the atorvastatin study, it was a phase 2 study, so they didn't look at any functional outcomes. The encouraging outcomes were based on volumes of chronic subdural.
Thank you. Second question. In Burr-Hall craniostomy, do you exercise the inner membrane under the microscope? Would you like to say anything about membrane?
So the inner membrane is what I call visceral membrane. So this is the membrane which is adherent on the brain surface. And I say, if it is tightly adherent and you can see cortical vessels clearly underneath with no fluid, then I wouldn't go near that membrane. You can then easily get a little bit of subarachnoid hemorrhage on the surface. You try and coagulate it, and then get a bit of subarachnoid hemorrhage. Those patients are elderly; they will get a seizure post-op, and just then a spiral of bad things that will happen. So the inner membrane really, said if it is tightly adherent, we just don't go near it.
Thank you, sir. Dr. Cafer Tayyar Kızıl from our clinic. When can patients who have to use anticoagulant or antiaggregant drugs start their treatment at the earliest? And second question, when do you start mobilization in operated patient?
Right, thank you. So again, very good questions. And in terms of the anticoagulants and antiplatelets, there isn't really any good evidence. We did a secondary analysis of our BNTRC big study, and actually we found that we should be aiming to start all those drugs as soon as we can to prevent the thrombotic complications, because patients who start them late had a high risk of thrombotic complications. What I tend to do in my practice is I tend to look at the indications. If it is a metallic valve, clearly, I would want to start the anticoagulation sooner rather than later. And I would tend to get a check CT, just have that CT as a baseline CT in case the patients then develop any new symptoms, be able to compare it. If the indication is AF, I would say, give it 2 to 4 weeks, perhaps do a scan, see what the scan looks like, and also evaluate the patient clinically. But, I say at the moment, some of my colleagues from Edinburgh, they are preparing a study, a randomized study to look specifically at these questions. In terms of, I think there is a second part of the question about when we start mobilization.
Yes.
Yeah, so I briefly touched upon this. So we don't actually restrict mobilization to these patients. If I show you our operative notes, we don't say bed rest for, 1 day, 2 days, or whatever. So, the same day, most patients don't really want to mobilize, but if some of them are able to mobilize and want to mobilize, we don't stop them. And then definitely, from the first postoperative morning, we encourage the nurse to try and mobilize them and get them out of bed. And, if you look at the multivariate analysis of that study that we conduct in the UK, there was a clear correlation between postoperative bed rest and worse outcomes. So I think, this is evidence that we should be trying to avoid it. But I appreciate that it's not very high quality evidence. It's not randomized.
Thank you for answers. Another question, Dr. İsmail Akkol from our clinic. I use dexamethasone 0.75 milligram daily for 2 or 4 weeks. What is your opinion?
Just to clarify, is this for patients who have been operated or for patients for conservative management?
I don't know.
Because, I guess the
Dr. Akkol, maybe you can write. Are they operated patients or non-operated? Oh, new message.
Non-operated patients.
Yeah. So, I would say that if you look at this study from the Netherlands, which was for non-operated patients, the study was stopped early because of much worse outcomes and complications in patients who had dexamethasone. It was a slightly different dose, but I think it's worth paying attention to the evidence from the randomized trials. I think at the moment, all the high quality evidence that we have from our study and from the Dutch study is that dexamethasone is harmful. I mean, I appreciate that the dose is different, that this is a really low dose, but yet, that's the evidence that we have. So, perhaps one way to find out is just try and do a study.
Thank you very much. Dr. Mehmet Seçer from Alanya Education and Research Hospital. What do you think about meningeal media artery embolization on treatment, subdural hematomas?
Yeah, so I briefly mentioned this thing already. So, we don't really use it in Cambridge. I think in the UK in general, people aren't really using it. I think around the UK, maybe 2 or 3 embolizations of the middle meningeal artery have happened, but it's not something which is widespread. I mean, in my view, as I said, surgery is really safe, very effective. So I would only reserve it for cases with more than 2 recurrences. I think, yeah, this is what I would say.
Thank you.
And obviously, we do need some evidence. The interventional neurosurgeons and endovascular neurosurgeons, interventional neuroradiologists, I think, on social media, they're very, very keen on showing the excellent results. But actually, we do need some studies, control studies, studies which look at the long-term outcome. You know, just showing a nice radiological control, you know, it doesn't mean anything.
Thank you, sir. Dr. Ayhan Kanat, in our study, chronic subdural hematoma, a total of 81.6% patients were males. What do you think about male preponderance in this disease?
It's the same as with our studies. So I think, you know, it's clear that male patients get a chronic subdural hematoma more frequently. I guess it's the same also in head injury, traumatic brain injury studies in younger populations. I think it's just because women are more sensible.
Thank you.
Alert, a colleague from Pakistan, Nurul
Yes.
Maria, she has a lot of questions. It's hard to read. Maybe it's better to turn on her microphone. She can ask herself.
Hello, sir. Thank you so much, first of all, for the wonderful lecture. It came past a very broad topic, a very important topic. I guess it is very common here, but we do not have a lot of data, and it is something that is very necessary for us to discuss. So thanks a lot for the wonderful lecture. That was very elaborate. Sir, I do have a lot of questions. First of all, that you have already answered, the MMA one, the embolization one. The other one is it was once thought that the AC inhibitors, the torvastatin and tranexamic acid, do have a role in chronic subdural hematoma. So do you really think that they do have a prognostic effect if say if some patients are taking these drugs? Do you think that those patients will have a better effect? And what about your view regarding the use of tranexamic acid in the chronic subdural hematoma? My other question include the closed versus the open drain. What would you like? Because it is another debate here that which one would you prefer, either the closed one or the open drain? Another thing was the use of the Foley catheter and single burr for chronic subdural hematoma. Here we have a center who performed this research, and they said that it is a very good technique to use Foley's catheter and a single burr, and it also reduces the incidence of pneumocephalus. And again, obviously, we have a lot of concerns regarding the incidence of pneumocephalus, which is seen very frequently in our setup. So if there is anything that you would like to recommend to prevent chronic pneumocephalus in patients with chronic subdural hematoma, especially regarding patient positioning, with you know, obviously in chronic subdural hematoma, you have to position the patient according to the intracranial procedure. But if he has got pneumocephalus as well, how would you like to position that patient? So this is there are a few other questions. I think I have already compiled 2 or 3.
I think it will be better if you ask one by one.
Exactly. Exactly.
Well, I can cover many of these already. Shall I take some of these now, and then you can keep asking? So I think, you know, in terms of ACE inhibitors, and we talked about atorvastatin and tranexamic acid. So my view with all of these is that there are some papers which have shown that are potentially useful. I haven't seen any high quality evidence from any, you know, good prospective control studies, randomized control studies. I think, you know, all of these drugs have potentially side effects. We have established that surgery is really safe. So, you know, I am going to carry on waiting for the results from any randomized trials before I change my practice. I mean, that is my view. It may not be a very popular view, you know, especially if, because, you know, people often want to try something and, you know, to be helpful. But I mean, my view, and I think, you know, certainly that of my colleagues in Cambridge, is that before changing our practice, we need to be waiting for some more concrete evidence. So I know that there are randomized studies happening looking at all of these. So I would, I'm going to wait for the results of those before I change my practice. In terms of the pneumocephalus, I think I briefly mentioned this before as well. So I think, you know, a trick is to fill up the subdural space with saline just as you're closing the skin through the subdural drain, and this way you can eliminate the pneumocephalus. Pneumocephalus really isn't a problem for us with the use of this technique. I think, the single burr hole, as I said to you, I can see a role for it, especially if you're using local anesthetic. But if you're subjecting somebody to general anesthetic, I can't really see why you would do a single rather than 2 burr holes. You have somebody who is fully anesthetized, you can just very easily do 2 burr holes. You get a better wash out because, you wash from one hole, the fluid is coming out from the other. It's not rocket science. It's a really simple concept. So if you have somebody who's fully anesthetized, I would do 2 burr holes. Local anesthetic, then I would probably do single burr hole. It's just simpler, quicker.
That's amazing, sir. Sir, thank you so much for all the questions. Sir, what would you recommend? The open drains or the closed drains, sir? Regarding the, obviously there is a difference of holes in that because the closed one has a hole in the tip, while the open ones have hole in the first 5 centimeter of the drain. Sir, what would you like to prefer, either the closed one or the open one?
Sorry, what do you mean? So we use a drainage system which is based on gravity drainage. So it's a passive drainage system, and this is just a silicone catheter. It's a small diameter and has some side holes, at the tip of the drain, which are in the subdural space, and that's connected to a bag which is draining outside. And say it's gravity drainage. There is no suction or anything like that. Is that what you mean?
Sir, I mean the drain. Sir, there is also some debate regarding the drain, which is either the open drain or the closed drain. The closed drain with a single or 2 holes only at the proximal end, the insertion end, while the open drain, which has several holes, it's in the proximal 5 centimeter of the drain.
Yeah.
So we usually do the open one. Yes, exactly. That's fine.
Mm. Yeah, we use that one. Yeah.
Yeah, exactly. So
Yeah.
we also use the open one. So, sir, is there? Do you think there is any difference of using the closed one or the open one? Because we usually use the open one. We do not have any experience with the closed one. So I'm a little confused over here.
I haven't used the closed one either, so I can't really tell you. I mean, I know that some people, are using EVDs, and it's fine. I mean, whatever works. But the point is that I think we have shown that the recurrence rate should be really low. Okay, so the 7% I appreciate is really low, but if somebody has a recurrence rate which is more than 10%, perhaps they should be looking to see what exactly are they doing that makes the recurrence rate very high. And I have to say that in the UK, the vast majority of these operations are done by residents, as in residents without a consultant even scrubbing in. So I suspect that it's the same also in Turkey or in Pakistan. But I say, despite the fact that these are being done by residents, you can see that the recurrence rate is really, really low.
Exactly. Thank you so much, sir. Sir, is there any study regarding the recently introduced direct oral anticoagulants that have recently been made an entry in this pharmacological world? Sir, do you think is there any difference that they have a reduced incidence of chronic subdural hematoma as compared to the conventional anticoagulants?
That's a good point. I don't think that I've come across such a study about chronic subdural. Sorry.
Yeah, exactly. So these are quite new, so I was a little concerned.
Sorry, we have to move on. Maybe
thank you. Thanks a lot. Thank you so much, sir.
Thank you.
Okay, Alaaddin.
Thank you. There are 2 questions. Gert one, I don't know.
Do you do a cortical membranectomy? You already answered it.
I think I've already discussed this.
Yeah. And Javad Ziyade.
Javad Ziyade, evet.
He didn't write where is he from. I am sorry if this is already discussed. I joined you late. What type of drainage system do you use and for how long? You said it's a gravity draining. And how long?
So we take it out after 48 hours. Again, it depends a little bit on the timing. So, let's say that we've done an operation Saturday, I don't know, 11 p.m., then I won't insist that it stays in until 11 p.m. on the Monday, when we have, only one resident covering the wards. If it's not draining huge amounts, I'll just tell the resident, take it out, in the evening. So, a few hours before. I think, with all these things, we have to be pragmatic and, yeah, so I don't insist that it has to be exactly 48 hours.
Okay. I will continue, Alaaddin, if you may.
And the last
But you
question.
prefer one borehole drainage or two borehole drainage in subdural hematoma? You have already said that you use two borehole.
Yeah, or one borehole if local anesthetic.
If you use local anesthetic. Okay. Özcan Karasu from our hospital says thank you very much for the wonderful lecture. And another.
Baran Taşkala.
Baran Taşkala. Okay, continue, Alaaddin.
Baran Taşkala from Istanbul. Thank you, Professor. It was really great lecture. In elderly patient, maybe 6 months enough for following. Is there any other recommendation in young patients? And other question about childs, especially early term childhood. Did you use subdural peritoneal shunt or other options for subdural collections? Thank you again for excellent lecture.
Yeah, I think, in terms of children, it's probably outside the remit of this presentation, to be honest. As you know, in children, especially, below the age of 2, then you have the issues around abusive non-accidental head injury and all those things. And, the infants, if you have fontanelles open, you can do fontanelle taps. It's basically a different disease, really. So I think, it's probably outside the scope of this presentation, if I may. And I'm not a pediatric neurosurgeon, so yeah, I don't really want to answer this.
Thank you very much for answers and your presentation. There is no any question. We completed the discussion part. I would like to give floor to Associate Professor Hasan Kamil Sucu.
Thank you, Dr. Angelos, for this high-level informative lecture. It was full of evidences for chronic subdural hematoma. Thank you again. Thank you for accepting our offer to speak in our conference series.
Thank you very much again for the invitation. It's a real pleasure. As you know, if I may take a minute, as you know, I work in the UK and I've been working here for a long time, but I'm originally from Greece, as you can guess.
Yeah, I guess from your name.
From my name, yes, yeah, exactly. So,
were you born in Greece?
Athens, yeah.
Athens, oh.
Yeah, I studied in Athens. I studied in Athens University, actually.
Okay, opposite to us, İzmir.
Yeah, exactly. So, but I come from Athens. But one thing to say is that the people from Greece and the people from Turkey, we are friends and we're neighbors. Yeah. So that's just as a closing remark.
Yeah, I have been in Greece many times also, in Athens, Thessaloniki, Meteora, etc.
Yeah, exactly. So the people are friends.
Yeah. Also, our foods are similar and delicious.
Well, yeah, exactly. Exactly.
Yeah. Thank you so much.
All right then. Take care. Nice to see you.
I hope we can meet in face to face.
Yes. Let's hope so. Let's hope so.
Not so far future.
Let's hope so.
Okay.
All right. Take care. Thanks again. Thank you.
Thank you, everyone, for joining us tonight. Thank you.
Thank you.